Welcome to our first panel for this workshop on the doctor-client relationship. My name is Ray Scher, and I will be the panel moderator. One of the themes of this workshop is the role that force plays in healthcare and the destruction it does. And this panel will focus on the role that force plays in interfering in the doctor-client relationship. To introduce our panelists, we have Astorino, a practicing ophthalmologist and co-founder of Americans for Freedom of Choice in Medicine, AFCM. We have Michael Cannon, Director of Health Policy Studies at the Cato Institute, also author of the new book, Recovery, of which we have free copies at that end of the room, so anyone here in person who wants a free copy, please take one. And we have Richard Parker, emergency medicine physician in Texas. And we have Mike Garrett, concierge physician, also here in Texas. So we got a lot of Texan physicians here. So we have people on this panel who have thought and worked a lot on thinking about how to conceptualize problems in the healthcare system and solutions. But before turning to the solutions, I would like to start with you, Art, and your story and how you got interested in these topics. And yeah, I think you have a very interesting story.
Sure.
Sure, how you got into this.
Yeah, okay, thank you. Yeah, as I was saying, I started an organization called Americans for Free Choice in Medicine, but you know, I graduated medical school really with just engineering and medicine and nothing about health policy. So in 1988, when I started practice in ophthalmology, shortly thereafter, you know, you come out, you're basically also an entrepreneur, you have to run a business, and I started getting these contracts across my desk, which were, the fundamental principle behind them appeared to be that I would do better the less I cared for my patients. And they were actually what we all know now as HMO contracts, and the fundamental aspect of it was capitation. And it seemed like, you know, that was an antithesis to my concept of the doctor-patient relationship. And other economists will go into more detail as to the rationale behind that rationing perspective, but basically I just didn't think it made sense. Then tried to think about why didn't it make sense, and what could we do to change it. And at the time I had thought about it, came up with a concept that I called health banking. It's actually other people in parallel thought of it, and they called it medical savings accounts and high deductible insurance. And started to think about that, you know, maybe this is one way to reform health finance, because I didn't like what was coming down the path with the HMO concept. Also, at that same time, the Clinton administration was starting the Clinton healthcare plan concept. And what I saw coming down the road with that was this huge bureaucracy. And it was, with so many offices, more regulations. Already I was dealing with, you know, Medicare in the beginning and so forth. And during that same period of time doing this thinking, I heard a quote, and I want to read it to you. And it said, "He has erected a multitude of offices and sent hither swarms of officers to harass our people and eat out their substance." Does anyone know where that came from? Right. Yeah. So I was driving, it was the 4th of July, and I was driving to see an emergency patient, and the radio station was reciting the Declaration of Independence while I was kind of thinking of all these things. And that sentence, just like a light went off, and I just said, you know, this is an issue of liberty. It's amazing that we're having to deal with this. So I got a little more active, and if you want to go, went to a healthcare policy.
Yes, please.
Went to a healthcare policy conference in DC. My father instigated that. Said, you know, you should really present your plan there. And I was very fortunate because I was able to hear other speakers and met some people that understand this a lot better than I did from a policy standpoint. People from Cato and NCPA and the Association of American Physicians and Surgeons, AAPS, Jane Orient. And I really learned a lot. And so I came away from that conference, studied more, and came up with 3 fundamental principles as to what's happening in medicine, finance. And it's consistent with everything else. about the history. And you've heard the history this morning, and so I'm not, fortunately that's great because I don't need to repeat it. But what we took out of that is, if you recall the tax code change, prior to that, individuals were responsible for their health coverage. And it makes sense, right? You're the one that's most interested in your health care, you know. But when they created that tax incentive, what they said is it's cheaper if you let someone else pay the bill. And the market responded to that. And for the 20 years between 1942 and 1965, there was a huge switch. Prior to that, there was essentially no employer-based health care. After that, it became 70, 80%. Now it's like 95% employer-based health care. And we ingrained in the American psyche that health care is something that someone else should pay for. Now, during that period of time, we found that health insurance still didn't rise tremendously high, any higher than inflation, because still people didn't want to go see doctors and have a bunch of procedures. But what it did, it created that psyche and it destroyed insurance, as was also discussed this morning, because somebody else was paying the bill. We separated the consumer of healthcare from the payer, and the mentality is in America, you got to get the best. I mean, so we did that. So we set up a system which he talked about the Blue Cross and Blue Shield, and this is really kind of critical to understand the finances. When Blue Cross and Blue Shield were set up, they were set up to fund hospitals, because at the time hospitals were were starting to become successful, but they needed capital. So they created a concept called cost plus financing. And cost plus financing means that you will basically, the census that you have in the hospital of your insurance, 20% Blue Cross or Blue Shield, you pay 20% of the cost of the hospital plus some profit. So then when Medicare came in, that's when things changed. And Medicare really boosted up the demand for medical services, and they paid the same way. So anyway, I don't go through more of the history. The point is, what we did with Americans for Free Choice in Medicine, we looked at all three sectors, charity, private, and Medicare, and we developed medical savings account type models for each of those. And I presented that to the Clinton Healthcare Task Force at the White House. And I showed, they listened, there were like 3 or 4 of them around the table. I went through how individuals saving money throughout this period of time, how the market forces of the individual payments would start to drive the market down, how the insurance companies would start to respond with different levels of deductibles and different plans and so forth. They listened patiently, but at the end of the presentation, they said, well, Dr. Astorino, that's really, really interesting, but you know, what we really would like to know is, where are your controls on the providers? And so I looked at them, and you know, I just realized that they had no concern for people making their own decisions, spending their own money, you know, building a great medical system. Their concern was really to control the doctors, control medical care, and have all the funding flow through them to have that control, which may be cynical, but that's what I realized. And so then I knew I really had an educational thing to fight, and came back to California and started giving lectures and started Americans for Free Choice in Medicine and tried to help develop this program or this plan.
Yes. And what's the most important lesson in terms of, especially arguing for tax equity during the 90s when you were fighting against the Clinton bill?
Right.
Why didn't that work? And what can we learn from that today?
Okay, so typically if I went through the history to explain to people what most people get, I'd say 80% of people get it. They can understand this, and they can understand the concept. Get that, you know, if you separate the finances from the provider, that eventually you can have a system where you lose choice. That's our name, Americans for Free Choice in Medicine. And what I didn't say is the principles are personal responsibility. We destroyed that with our tax code. Free market economics, we destroyed that by destroying the vehicle of insurance and healthcare. And then we'll destroy choice. And so the HMOs came, and now you can't choose your doctor, you can't choose your specialist. Doctors can't choose how they practice medicine. They have protocols. Hospitals can't choose how many beds they can have. You know, all the stuff that we went through in the beginning. So the complete lack of choice. Mm-hmm. And I think that that's what we have to focus on in the education process, is that we need to provide that choice to individuals. and that the way to do that is through many of the things that we're going to discuss today. And I think the whole point is just figuring out a way to get that politically viable. And they're starting to do some of it. Like medical savings had to get through, and we did stop the Clinton plan, but we didn't stop the Obama plan.
Thanks for that. Michael, you've got your new book out. What do you think are the biggest barriers to the kind of solutions that you're proposing? And would you like to comment on Art's story in terms of reflecting on past battles that we've tried to launch?
Sure. I'll lean into the mic so that the folks in the interwebs can hear me. I want to first say thank you to Salem. Thank you, Greg. Thank you, Ray, for having me here. Thank you all for coming. And also thank Greg and Amesh for great presentations with a lot of information about how often, to what extent, the decisions that happen in the U.S. health sector are not a result of people exercising their right, their fundamental human right to make their own medical decisions, their own health decisions, but are instead the result of coercion, the result of coercive processes. And if Michael, if you could call up 4.1, I got a couple slides that I think will help illustrate just how pervasive coercion is in the U.S. health sector. The figure that Michael's going to bring up is from that we put together at Cato using data from the OECD. They compared advanced nations. The OECD compares advanced nations on all sorts of things. You've seen measures of how much more the United States spends on healthcare than other countries, and on a per capita basis, and as a share of GDP. But they also collect data that I don't think I've seen anyone else publicize other than we at the Cato Institute that show or that measure the extent to which health spending within a country is the result of voluntary choice by individuals versus government coercion. Now, you would think, if you listen to the rhetoric about health policy debates in the United States, that the United States would be among the lowest, among advanced nations, we would have among the lowest shares of health spending that are the result of that is the result of government coercion. Instead, the opposite is true. We're among the highest nations in terms of compulsory health spending as a share of overall health spending. It's about 85% of health spending in the United States is spending that either you devote your money to this type of medical spending, the way what the government tells you got to use it for, or there's going to be penalties. The government is going to fine you, ultimately imprison you, unless you do what the government wants. The largest about half of U.S. health spending, so 50 percentage points of that 85%, is direct government spending, the Medicare program, the Medicaid program, the Veterans Health Administration, and so forth. But another 35% of it is what we call, quote, private health spending. It's spending on employer-sponsored health insurance. We heard a little bit about this before, and the tax exclusion for employer-sponsored health insurance. What that really does is it says to workers, either you let your employer control really $24,000 of your earnings and use it to choose your health plan, a type of health plan that the government really mandates, which is employer-sponsored coverage, which, by the way, is terrible coverage. It's terrible. Everyone in this room who has employer-sponsored insurance, you have terrible health insurance. If for only one reason, which is that when you change jobs, it disappears. What kind of crappy health insurance is that? Would you ever buy that insurance on your own if the government weren't penalizing you otherwise? No, you wouldn't. But if you take that $24,000 as cash wages and go to buy your own health insurance, the government taxes you on it, and with an average marginal tax rate of about 33%. So you lose $8,000 of that. And if you decide to assert your freedom and say, no, that is unjust, that is unfair, I, as a free autonomous individual, I'm going to spend my money, exercise my right to make my healthcare decisions however I want, I'm not going to pay that $8,000 to the federal government. They'll fine you, they'll put you in jail, they'll take away your freedom. That's coercion that is propping up the system of employer-sponsored insurance and adding that extra 35 percentage points to the total here on this graph, which means the United States is about number 8 in terms of compulsory health spending. Not at the bottom, which is, I think, Mexico. Is that who it is? Mm-hmm. Yep. At about just over 50%. But 85%. That is more than the OECD average. That is more than a greater share than in Canada or the United Kingdom, which have explicitly socialized systems. And it's only just a couple percentage points away from the Czech Republic. Although that's 2020, I think it might be Norway now that's at the top. They bounce around a little bit. But we're still at number 8 and still only 2 or 3 percentage points away from the nation where the government exerts the greatest amount of control over health spending. And I'll just show you one more chart right now, if Michael will oblige. Figure 4.2, which is the one that looks just like this, but is a little different. It shows those same data, but instead of as a share of compulsory health spending as a share of health spending, it shows compulsory and voluntary health spending as shares of GDP. One thing that you'll notice is the United States here isn't number 8, we are number 1. Because we spend so much more on healthcare than any other country, we spend the largest, the greatest share of GDP on healthcare, and that also means that compulsory health spending in the United States is larger, consumes a larger share of GDP in the United States than in any other advanced nation. It's about 16%. That's so high. Not only is it greater than the share of compulsory spending that every other nation, share of GDP that every nation spends on compulsory health spending, it's a greater share of GDP than total health spending in any other country. So when people lament the U.S. health sector, why do we spend so much and why are we out of line with all these other OECD nations? The answer is because our government forces us to spend that much. It will put us in jail unless we spend that much. And when it does that, it takes away our right to decide how we're going to spend that money. It tells us we have to enroll in an employer-sponsored plan. We have to give money to the Medicare program. We have to give our money to the Medicaid program, and then the government gets to decide how that how people spend that money, and that violates, I mean, not only our rights, but they don't spend it the way that we would spend it. A lot of people would prefer to enroll in HMO plans, but they cannot because their employers don't offer those plans. And we heard a little bit about HMOs a moment ago, but I was just texting my sister-in-law so that she could remind me what was the name of the tumor that she had removed from her brain. Vestibular schwannoma. It was a benign tumor. She also called it an acoustic neuroma. It was right by her acoustic nerve on her left side. They had to cut her acoustic nerve, so she's totally deaf in this ear. If you know my brother, that's maybe a blessing and a curse. But when she describes the experience she had, of course, the surgery, you know, this is a traumatic experience, but when she describes the quality of care she received, she speaks in superlative terms because the staff was compassionate. Everything about it was as easy as it could have been. If she had to fill a prescription, it was in the same building or on the floor below. If she had to talk to a specialist, if she was with her GP and had to talk to a specialist, the specialist was down the hall, and so was the other specialist and the other specialist. And the reason for that was she was in an HMO. She was in an HMO called Kaiser Permanente. It's really the only fully integrated HMO in the United States, at least on the private side. Not totally fully integrated in the DC area where I live, but close enough that she had a wonderful experience that would have been just so much worse in her view, and probably mine. If I were undergoing what she went through, I think I would like to be in a Kaiser-like HMO because she would not have had the convenience of having all of those individuals working for the same institution in the same facility, making things so much more convenient for her. There are people out there who prefer those types of plans, but not only does the government penalize them if they choose those type of plans, it effectively penalizes employers if they choose those sorts of plans. And so we all think that the norm is independent practice where physicians in small groups or independent groups work at arm's length with other physician groups and hospitals and pharmacies and so forth. I think one reason we think that that's the norm is government intervention, but the main point is that that the government takes away your right to choose whether you are going to sign up for a health plan with what we call fragmented or independent, a fragmented delivery system, or with an integrated one, and that has not only the giving government the power to make these decisions for us, has not only taken away our right to make these decisions ourselves, given us a government-dominated health system. It is also the primary reason why health spending in this country is so high, healthcare prices are so excessive, and the quality of care is not what people claim it is when they say that the U.S. health sector has the best health system in the world. The quality of care is actually alarmingly poor in many areas of the U.S. health sector, and we can trace almost all of it back to this chart and what it tells us about who's making those decisions.
Thanks for that, Michael. So the big picture perspective is that we want patients and doctors to regain control over the funding of healthcare. And one way to do that is to, again, push for tax equity so that individuals can purchase their own healthcare. They're not punished for not buying employer-based health insurance. But how do we actually convince people, both patients, doctors, the whole system of that? And that's a question to the whole group. Yeah.
Well, we kind of talked about this last night. I personally think that, you know, in a democracy, or in a semi-democracy, or constitutional republic, or whatever you want to call what we have, in order to affect change, I mean, the powers to be are the individuals that can have the power to make decisions for us. And in our system, it's politicians. And when you think about it, there are two things that politicians are interested in. One is money, and the other is votes. And so money is a bit difficult sometimes, but votes, you have to have a constituency. And I think, and that involves education. I think that's one of the things that we talked about, that, you know, you talked about, and Mike did. So now how to go about that, I think, is something that's, you know, kind of difficult to try to, off the top of my head, to try to, you know, think about. But I think that's essentially what we have to do, is education, and I think it has to be brought home in direct terms to, you know, to people, what all this really means to them on a day-to-day basis. Mm-hmm. You know, what is it that they are losing when they think that they're getting quote-unquote free health care? You know, and I think a lot of this goes to what Greg said. You know, all the things that you don't see, that don't happen because we are being controlled, we are being regulated. And so, just kind of in general terms, that's kind of, I think, that's where my thoughts are right now on that.
Okay. Thanks, Richard. Did you want
if I could, if I could just tweak what Ray said, I would say the important thing is not to allow patients and providers to control the health spending. It's to allow the patient to control the health spending. As a provider of health policy analysis, I would love to control the money that funds my activities. I would love to be able to go to Cato Institute sponsors and tell them how much, and have control over the money, how much money they give to the Cato Institute, what they can, what sort of expectations they can have and work they can expect. But we don't allow that in any other sector of the economy. And so I think it's, and when we do, the problem with the health sector is that the providers do have too much control over health spending. The reason that we spend so much money on healthcare in this country is not just because government asserted all of that control over all of these health decisions and then said, you know, it would be great, more spending, more wasteful spending, more spending on inefficient business models and that sort of thing. What happened was government got these powers, a lot of the powers it got at the behest of physicians, and then, as often happens whenever government gets power to regulate or subsidize part of the economy, the people whom the government is regulating or subsidizing then because they have the greatest interest in how these how the government makes these decisions, they launch intensive lobbying campaigns, and they end up capturing the processes that determine how much they receive in subsidies and how the government regulates them. So I just want to tweak what Ray said by saying that we don't want providers to have control over health spending. We want consumers to control that spending, because then the system, the providers, will serve the consumer's needs rather than the provider's needs.
Yeah, thanks for that. I just wanted to clarify. So by control, I meant voluntary control. And surely it's not only the patient's rights to control healthcare funding that we should defend. We should also defend the right of doctors to organize into groups, and medical corporations. They also have a right, and their rights also have to be defended. And that's what I meant.
Mm-hmm.
Yeah, actually, I want to chime in. So, number one, I agree with you about Kaiser certainly was done before the HMO Act. Kaiser started with the railroads. And it is a different model than the HMOs that were developed after the HMO. And HMOs have definitely evolved since the Act to provide sometimes excellent care. And my principle isn't about choice, but it's interesting you say providers shouldn't control the dollars, because that's exactly what happens in Kaiser. That is, it's Kaiser Permanente of doctors. And the doctors are the ones that get the money, and they control the care. And yet you said you like that system. So
right.
Is there a contradiction in what you just said?
I don't think so. So Kaiser, if the consumer is the one who's choosing a Kaiser type plan versus another type plan, then it is ultimately the consumer who is making that decision about and controlling the resources. And the doctors only get those resources if the consumer says so. And that's how it works in every sector of the economy. The independent practice physicians also, if consumer in a free market, would only get to control the money that the consumer gives them, and the insurance companies and all down the line, if the consumer, if the consumer consents, if the consumer is the one who's making the ultimate decision about who's going to get to control those resources. So they're the ones who are in control. A problem exists with Kaiser that exists with all other types of health plans, which is that workers basically get to choose only those health plans that their employers make available to them. Usually employers only offer them one plan. If they offer them two, it's just two varieties of the same plan with different levels of cost sharing or out-of-network coverage. And it's rare that an employer will give their workers a choice between a Kaiser type plan and a non-Kaiser type plan. My sister-in-law, I can't remember. I mean, she works for a large school system, and I think she does have the choice between a Kaiser and non-Kaiser type plan. My wife worked for the federal government. Of course, Congress and federal bureaucrats have more choice than most Americans do when it comes to health insurance. They could choose between a Kaiser plan and fee-for-service type plans. But what makes the Kaiser model able to pull off those dimensions of quality is not that the doctors are controlling the money per se, but the way they organize themselves into an integrated delivery system that has a health plan that is basically part of the same corporate entity, so that they face totally different incentives than the rest of the health sector faces.
Just had a question, just to get your clarification on this. When you say doctor controlling resources, what exactly do you mean? I mean, when a patient comes to me and they're sick, and we decide, well, we should do a CT scan to treat this. Where is there? I don't understand what you mean by control. Who's controlling the dollars there? Isn't that a joint decision that's being made? So
if the patient, there could be a couple of different scenarios here. One is if the patient is paying with her own money, then the patient decides whether the resources are going to go toward a CT scan or not. If the patient is paying through insurance, then the insurance company is going to have a say, or through the government, then the government is going to have a say.
Right.
And if the patient is choosing her own insurance company, then the patient is still in control here and can choose a different insurance company that has different prior authorization rules or whatever. And if there are more permissive rules, the premiums are going to be higher. And if they are willing to pay that cost, that's fine. But I think in all of those cases that I've described so far, the patient is the one in control. And while that might frustrate doctors, I don't think it frustrates doctors nearly as much as what is the norm right now in healthcare, where it's either the government paying, and so the patient doesn't have a whole lot of say. I mean, actually, let me come back to that in a moment. The patient is enrolling more often than not in a private health plan that their employer chose under prior authorization rules that the patient might not prefer, but the government penalizes her if she enrolls in a different plan. So there, the government is controlling that decision and controlling those resources, and also delegating some of that control to an employer to make on the enrollee's behalf. I wanted to amend what I was saying about government plans, because whether it's Medicare or Medicaid, the patient doesn't have to enroll in either one of those. The patient, if a patient enrolls in the Medicare program, then they're basically voluntarily signing up for whatever limits the government imposes on their coverage, because they want that enormous subsidy that the Medicare program is providing them. And the patient might not have the resources to do it, but at least has the freedom to go outside of the Medicare program and pay for you by not enrolling in the Medicare program, and pay for that CT scan directly, in which case the patient does control the resources.
Thanks for that,
Yeah.
Michael. I do want to move on to another topic, and it's a topic, Richard, that you said that you were interested in. So one way that the doctor-client relationship is interfered with is the issue of price transparency, or rather the lack thereof. And it's something that Greg mentioned in his talk, is it's by seeing a price that we are able to weigh our values. And Congress passed the No Surprises Act as a solution to this. And Richard, could you start by explaining this act and the consequences of it?
Sure. Well, the No Surprise Act was passed in 2020. It was, it was a big bipartisan bill, and I think it was the last bill, one of the last bills that Trump signed, and it took effect in 2021. And what this piece of legislation essentially does is that it, talking about control, in essence, it pretty much gives insurance companies, so-called quote-unquote private insurance companies, the power to essentially to deny claims at will, to essentially through the government to set prices for physicians that are out of network. Mm-hmm. So basically, so I have two choices as a physician. If I want to deliver care to a patient, if I want to deal with privately insured patients, and I put that in scare quotes because I think what we learned today is that it's not really private, but and I can negotiate with the insurance companies up front what I can charge you or what I can bill you for certain services. If the insurance company and I can't come to an agreement, then I have a choice to quote unquote go out of network, essentially. So then I can bill at cost, or I can bill beyond cost, whatever I and the hospital group or whatever decide what they require in order to meet those services, to meet that demand, essentially. Mm-hmm. So what the No Surprise Act does is it takes away that the ability to negotiate with insurance companies out of network prices, and it puts a arbiter in between, which the government, of course, picks. So then you have a third party, an arbiter determining what the insurance company must reimburse me for, and the price basically is determined by whatever the arbiter thinks. So right away, whatever free market mechanisms that existed at that point are gone. It's an arbiter. It's somebody else. Mm-hmm. Another person decides, well, yay, nay, this should be this much. So, and the insurance companies, it's what happens in practice is that they delay, they deny, they delay, they delay, they delay. And so it can take you up to 2 years to be reimbursed for a service that you provided 2 years prior. So, and what insurance companies can now do, essentially, and again, I mean, I don't want to get into the nitty-gritty of this because it sounds like, yeah, what you have is two pressure groups. Mm-hmm. You have doctors, and then you have insurance companies, and now they're at each other's throat. But it's because of government force that that's happening. Mm-hmm. And in the industry, and my colleagues and the physician groups that I'm involved with, this piece of legislation is more significant than Obamacare. Mm. It truly is.
Because of the
because it's price controls.
Now, the original reason for that was supposedly so that patients aren't surprised by unexpected bills at hospitals, and so, which I didn't even hear anything about because most likely, and I don't know this bill, that's why I'm asking you. So how is it that you got that unintended consequence from a bill that's supposed to just say, oh, hospitals should let patients know what they're going to be charged, when services are provided?
Well, which
I assume is what the purpose of that bill is supposed to be.
That's right. Because of lack of transparency.
Right.
Right. So yeah.
But how did that result in this arbiter between doctors and an insurance company? I'm just curious as to how do they throw that in? It seems like it doesn't even relate, but it may in some way.
Well, I think the purpose, at least the stated purpose of the government, was to increase transparency. I mean, that's the stated purpose. I think the real purpose is to drive us further into single payer, basically. Well, so, I mean, I don't know. Does that answer your question? Or?
Well, yeah, but I was actually going to make another point with that. Is that, I mean, for the audience, that whatever we put into these bills and whatever they're titled as to what they're expected to do, it never results in that because of the administrative state that it creates afterwards. So I just want to give a quick example. If you know anything about Medicare, you know that it basically sets your prices, it fixes it, tells you almost what you can do or who's qualified for this. I mean, I think it's 10 stories worth of paper of regulations. However, in the original act that was signed, it said the following. Section 1801 states that nothing in the title is to be construed to authorize any federal office or employee to execute any supervision or control over the practice of medicine, the manner in which medicine services are provided, or personal policies of practices of healthcare, or the operation or administration of medical facilities and personnel. So that's what the law states. Now, so when we talk about trying to get certain wordsmithing in a bill, it's almost irrelevant because of the administrative state and the policies and regulations that come down after it. I mean, I'm not stating we shouldn't do it. It's just we have to be aware that someone's got to also reduce the administrative state because it's going to, the reason that happens is because we're basically allowing them to finance the care. You can't have someone else paying the bill and not eventually, because when this bill was set, the politicians said all we want to do is pay the bill. But we know as a fact through this whole third party that if you give the person the right to pay the bill, eventually they're going to tell you how to spend your money.
I've got a question for Mike now. How does direct primary care fit into this?
So I think largely direct primary care is a response to all these problems. I mean, we have this, Frankenstein's monster system that's largely socialized, and people are, both doctors and patients, very frustrated and fed up with this system of regulations and controls, and trying to seek little pockets of freedom or ways outside of it. And I think direct primary care essentially and concierge practices have arisen out of patients' frustrations with the system, with getting access to care, timely care, physicians that have time for them, and physicians' frustrations with the system, with basically working for a third party instead of for a patient. So the direct primary care model it's removing the third party from the doctor-patient relationship and restoring that relationship to making it a direct financial relationship between the patient and the doctor, and it basically is a free market solution that allows their interests to align. I mean, a lot of these problems that we're talking about are because that someone else is paying for it. And so you get, when you have a big, largely collectivized system like this, you naturally end up with different people warring and trying to sort of get their piece of the pie, where the third party's paying for it, and they're all lobbying to get their part of that. With direct primary care, basically you're trying to align the interests of the physician and the patient, and the patient has to, or the provider, the physician or provider has to show the patient the value for them to get the money out of their pocket and make a choice to come. I have to show them the value. They're not gonna, it's not because their employer says they should do it, or Medicare says they should do it, or Medicaid, or anyone else. I have to provide the value to them that they see, it worth them paying for that. So I think it's arisen largely as a partial solution, a little pocket of freedom to try to avoid some of these problems that are inherent in a collectivized system.
I think there's a way to tie together a lot of things that we've mentioned here, and Amesh provided it very ably in his talk. Whether it is the lack of options like DPCs, which are, to my mind, really small-scale partial Kaiser Permanentes. They share features with them. But also the No Surprises Act, the lack of price transparency, the HMO Act, we've mentioned that. Some of the things that have come up before is these are all downstream effects of the government interfering in healthcare and then causing problem after problem after problem, and then government trying to solve the problems that it created, but never actually doing it, and certainly never fixing the original problem. The original problem, what I like to call the original sin of U.S. health policy, is what's responsible for that 35% of health spending that is ostensibly private but still compulsory, employer-sponsored insurance. The tax exclusion for employer-sponsored insurance, which emerged before World War II's wage and price controls did, it's the main reason we have an employment-based system that covers 57% of the public, and is the cause of or exacerbates every single problem that we see in the U.S. health sector. By the way, these charts come from my book, Recovery, which is available right over there. I've also got in the book a list of just some of the things that Congress has tried to do to fix the problems that the exclusion created. The exclusion threw people out of their coverage after they retired because you lose your job, you're not working anymore, you don't have employer-sponsored insurance anymore, so Congress created Medicare. It increases the prices for medical care and health insurance to the point where some people couldn't afford it, so Congress created Medicaid to help those people. It punishes health maintenance organizations for reasons that I mentioned before. So Congress created the HMO Act of 1973 to promote them. It punishes electronic medical records. The COBRA, HIPAA, CHIP, all responses to try to fill gaps that in the health sector that the Congress created with the tax exclusion. The HITECH Act, which encourages electronic health records. The exclusion punishes electronic health records because it punishes Kaiser-type plans that just naturally offer them. I mean, Kaiser's been offering some form of electronic health records since the 1960s. And to this day, bills itself as providing higher quality, more convenient care to people, in part because it uses electronic health records and did it without any government encouragement. And finally, the Obamacare in 2010 and then the No Surprises Act in 2020, Obamacare exists to fill cracks in the health sector for people who lose their employer-sponsored coverage before age 65. And the No Surprises Act, well, what that act is about is people getting these surprise medical bills where the prices are outrageously high, and government trying to, as we were discussing, come up with a price that's not quite so bad, which is government price setting. And it's
take exception to that.
And it's a terrible idea, but the reason we have it is because there's so many is because of the tax exclusion, which encourages the proliferation of surprise medical bills through a number of mechanisms, one of which is discouraging Kaiser-type plans where that's less of a problem, and also encouraging higher prices so when those surprise medical bills hit, they are conscience-shockingly high in many cases.
Richard, would you like to?
The real purpose of the problem with the No Surprise Act is the out-of-network, in-network pricing, and the confusion that arises around that when patients go into a hospital, and the hospital is in network, and they're told that hospital is in network, and then they're seen by a ER physician, or they're seen by an anesthesiologist, and that physician is then not in network, and then he charges, he or she,
And the patient doesn't know.
and the patient doesn't know, right? That was the problem. It was not outrageous prices and all that. That was the essence of the problem, and at least as stated by those legislatures that.
So that's very consistent with what I was describing, because in an integrated system, the anesthesiologist works for the system. So you're not going to get a surprise bill that way.
That depends on the system.
And if you want examples of outrageously high prices for surprise medical bills, I can provide them.
Oh, I know.
Kaiser Health News does a series called the Bill of the Month series that's all about just how ridiculously high these are. In our audience, one of Cato's adjunct scholars, UT Austin Professor Charlie Silver, professor of law here at UT Austin, wrote a wonderful book for us at the Cato Institute that had example after example of these unconscionably high surprise bills that people were receiving. We made videos about them. You can find them on our website. Some guy got charged, I think, $86,000 for antivenom that costs $150 because he went to an out-of-network provider.
By the way, those prices are never paid. But anyway, that was the purpose of the bill.
Right. Richard, I am interested in how should we think about the lack of price transparency? Is this only a problem that we can solve long-term by changing the system, or are there specific policy proposals we can put in place that address real issues? Because there does seem something strange about a patient going into a hospital and getting a surprise bill if they're not told that they've been seen by a doctor that's out of network. So is there some kind of solution that...
That's that's one of those questions, what would the healthcare system look like if it were not government control, or if it were not, force wasn't being used in the healthcare system? That's something that's very, very difficult to answer. I would imagine that if there were such thing as a free market system, the marketplace would take care of that. I mean, if you had a hospital that was charging, I mean, if I go to Apple and they're charging me $20,000 for a phone, and then I have the freedom to go to Microsoft or Samsung, and they pay, and they charge me $1,000 for the same phone, where am I going to go? I mean, it's just, so it's one of those things where because we have force, everything gets skewed, and then lack of price transparency. I have problems when I go to the hospital trying to figure out, is this anesthesiologist, is this person on my network or not? I have to ask. But I think the free market would take care of that problem very, 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 very quickly.
Yeah, on that note, I think we talked about what's happening in India last night at our discussion, and one thing is to free up the ability to make hospitals, right, with the certificates of needs. Our hospitals are it's institutionalized, that cost plus finance that started. It's just made hospitals so ridiculously expensive because the original accounting had nothing to do with the service the person got.
Right.
So they had to actuarially take their costs for that month and distribute it into the services that the patient had, and so that's $10 Tylenol bills and other things. And I think that mentality is maintained, the concept that it should be less costly to do care. If we had an ability to create more freedom in hospitals. It's interesting, he was discussing in India, they'll have hospitals with only 15 beds or something. I mean, there could be all kinds of different systems in the market developed for certain kinds of emergencies or non-emergencies or whatever, and we'd have a whole variety of things very cost effectively, which is to your point, that the market would provide that. And
it wouldn't take very long.
Right.
In fact, it would take overnight. So.
With that, I would like to turn to another topic. It is quite interesting that often the way physicians are able to practice medicine has a lot to do with their specialty. And I want to ask both you, Art, and Mike, what's it like operating for you, Art, as an ophthalmologist, and you, Mike, as a concierge physician, in your ability to practice medicine, because you have a relative amount of financial independence? And then I'd like to follow that up with questions of how can we create systems like that for other physicians and other healthcare networks?
Want to go first, Mike?
Yeah, sure. So, yeah, I mean, in my model, you know, price transparency is a key thing, because again, I'm outside that third-party system, so I'm asking people to, you know, to pay. I have to tell them the fees, like it's a market solution, so they have to be able to know. And with direct primary care or with concierge, they can plan as far as their primary care the entire year. They can know in advance what they're going to spend. So, you know, it's predictable, it's knowable, they know it in advance, and they can then make a choice whether they want to choose that, you know, that level of care or not. And then from the provider standpoint, I think what part of your question raised, just I have autonomy in terms of my practice model, my financial decisions. I mean, it has to be reality based, in that I have to, you know, price it at such a rate that people will be willing to pay it. But since I'm outside of that third-party payment model, I do have some autonomy in deciding what those prices, you know, can be. Now, there's all kinds of ways in which my, you know, independent judgment autonomy is affected by, you know, government regulation at every single level. But in terms of just the financial part of the practice, I do have autonomy for that. You know, I'm able to do that, and I just have to make it, you know, be a good value proposition for each individual to decide, and that makes it economically viable.
What feedback do you get from your patients?
Pardon?
I was going to say, what feedback do you get from your patients going from the care they used to have to the concierge practice you're able to provide?
So I generally get great feedback, and that's true of direct primary care models and concierge models. You know, the system is so broken, and everyone knows that they deal with so much bureaucracy and frustration, and they don't always know, they don't understand what all is behind that, why it's that way, but the experience is different. I mean, they call and a human being answers the phone. They need something and they text me and I text back. I mean, it's a totally different experience than what people are used to in kind of the traditional third-party payment models. So, you know, patients routinely give, you know, feedback that they love that. And again, I mean, part of it is they'll tell me all these horror stories, experiences they've had before, and, you know, rave about the experience that they have in a concierge type model or a direct primary care model. But part of it is, you know, they're voting with their wallets and their dollars. Like, you know, if they're coming back and paying you month after month and year after year, and you go out of business if they're not, that they're satisfied with the care. None of them are being sent there because their employer says this is the only option, you know, and I'm on a list of 8 providers in Austin or something like that.
So I've got a question about that. To what extent do you think that the kind of expectations and culture has changed for physicians in terms of concierge medicine being more as a viable option than it was a couple of decades ago? And also with patients, like, how many more patients are seeing that as something that they can actually do?
So with concierge, I'm not really sure. I mean, I know that's been around for at least a couple decades, more than that, I think. The direct primary care model, which is very similar, shares more similarities with concierge than differences. That's really grown tremendously in the last 10, 12 years. And it's essentially a very similar model to concierge, except at usually a lower price point. And the doctor will typically have, in a concierge practice, often they'll have 200 or 300 patients on their panel. In a direct primary care practice, they'll have 500 to 600. Traditional primary care doctor may have 2,000 to 3,000 that they're responsible for, and that's why then, because of the third-party payment model and the collectivized system, it's why people realize that, you know, their doctors are seeing 20 to 30 patients a day. They have 10 to 15 minutes. They don't have time for them. So yeah, it's definitely become a more viable model with the introduction of the direct primary care model, making it much more widely affordable. You know, with a concierge model, that does, you know, there are fewer people who have the means to be able to afford those higher price points. But direct primary care, I mean, when I was practicing that way, I would routinely tell people, if you can afford a gym membership, a cell phone, high-speed internet, you can afford high-quality, personalized, individual care with a primary care doctor who knows you. You get unlimited office visits, no copays, and essentially everything they do in that office for a very modest monthly fee. So it's definitely a more viable model over the last 10, 15 years.
Thanks, Mike. Michael, I've got a question for you. How can we reform the payment models to allow other doctors, let's say, for example, Amish, who's an infectious disease doctor who's tied to a hospital, to gain more financial independence so that they can gain more clinical independence?
I'm not, well, I don't like talking about payment models and reforming payment models, because it makes it sound like the reformers should decide what the payment models or the payment systems should be. I don't want the government deciding whether Uber charges me by the mile or according to zones, which is how it used to work with cabs. I don't want them deciding what the prices are going to be for within those different models. I think the way to reform payment is to change who controls the money and let consumers, without a thought to whether this is a capitated model or a fee-for-service model or some sort of bundled payment hybrid model, just chooses their health plan and their healthcare providers based on price and quality. Different models are going to promote different dimensions of quality, and different models are going to have different impact on, are going to have higher and lower premiums. Let the consumer control that $4 trillion that we're spending on healthcare in this country, and let them gravitate to the models that they like best. There was an interesting survey that Atul Gawande did of HMOs, of health insurance choice, and they found that that consumers who had a choice, you remember in the 1990s, everybody hated HMOs. They were limiting what doctors could, what the insurance companies would pay for doctors to do. There's this huge backlash against them. In the midst of all of that, he does this survey and finds that actually people who choose their own HMO like them. And it was the people who didn't like their HMOs were the people whose employers chose it for them. So let them choose, let them control the money and choose among different payment systems. They won't even know they're choosing among different payment systems. They'll just know about the things they care about, which is prices and quality. And how do we do that? Well, $4 trillion is a lot of money. Even 85% of $4 trillion is still a lot of money. And it's not all in the same, it doesn't flow in all, in just one way. There are different revenue streams, funding streams there. One of them is through millions of employers. The biggest source of compulsory health spending in the United States is employer-sponsored insurance, $1.3 trillion of compulsory spending per year and rising. To change that, and so that it's not the employers who are controlling it, but the workers, you need to change the tax code. In the book, Recovery, I propose a way of doing that so that workers can control that $1.3 trillion of their own earnings. On an individual basis, level basis, if you've got family coverage, that's like $24,000 of your earnings that you don't now get to control, but you would, $17,000 of which you don't even realize is part of your compensation. So it would be like getting a salary boost of $17,000. Let them choose that. Let them choose their employer plan or any other plan without penalty. And it would be helpful if we could give them alternatives to Obamacare so that they'd have a broader choice of plans. With regard to the Medicare program, I also talk about in the book how to reform that. Instead of giving people what is essentially a voucher where they can choose between a government-run Medicare, traditional Medicare fee-for-service plan, or these private Medicare Advantage plans, really level the playing field between all of those options, like the public option advocates say we should. And the only way to do that is to give seniors their Medicare subsidy in the form of cash, unrestricted cash, where sicker people get a bigger check, healthier seniors get a smaller check, wealthier enrollees get smaller checks, lower income enrollees get bigger checks, and then let them choose the health plan that they want. And you will get much more dynamism in the health insurance and healthcare markets for health insurance and markets for healthcare delivery, and you will see prices plummet. You will see healthcare come within reach of people who cannot afford it today, because when those seniors are spending, and the 6% of the population who have employer-sponsored insurance begin spending all of that money, we're already talking about more than $2 trillion, more than half of health spending, begin spending that money as if it's their own, because it would be. where they get to see the savings from comparison shopping, you will see prices plummet. And that is the most important thing we can do to make healthcare more universal, is to drive down prices. I've got another chart in the book where I explain, where I present evidence showing that when you make consumers price sensitive, they beat insurance companies at negotiating lower prices with providers. So those are just two reforms. There's also the Medicaid program. The book has something to say about that, and the Veterans Health Administration, but I'll just stop right there.
Oh, Michael, what about the barriers that Medicare imposes on physicians who want to operate out of the system, especially specialists?
Out of which system?
The Medicare system.
There aren't any.
There are no barriers.
No.
I see.
What do you mean by barriers? Why do you think there are barriers?
Well, aren't there barriers for some specialists in terms of how they get paid, and they're basically have no other options?
Something you have to understand is that the entire debate about healthcare in the United States is so physician-centered, physician-friendly, that it's basically pro-physician propaganda, okay? Pro-physician cartel propaganda. And this is one of those manifestations. There are no barriers. Medicare presents no barriers to how physicians practice medicine. What it does is it says we won't subsidize certain stuff. Okay? That is very different. Licensing presents barriers to how physicians practice. Medicare does not. Medicare just says we're not going to pay for certain stuff. But physicians have convinced most health policy people who talk about these things that not subsidizing me the way I want the government to subsidize me is a barrier and a threat to my freedom. It is not. That passage you read are from the original Medicare statute, saying that the government shall do nothing to interfere with how physicians practice medicine. That was carte blanche to let physicians do whatever they wanted, and the government was going to subsidize it. That wasn't a good provision of the law. That was an awful provision of the law. And it was not, because what it meant was that physicians could provide all sorts of low-value care to patients, and the Medicare program couldn't say anything about it. And the best research available has shown that 1/3 of what physicians order up for patients in the Medicare program does absolutely nothing to make them healthier or happier with the care they're receiving. That is hundreds of billions of dollars that taxpayers are wasting on zero-value care for people, money that could be spent on high-value care for other people, or on better housing or better nutrition or education that improve health outcomes. But because physicians basically captured the Medicare program, no, the Medicare program just keeps paying and paying and paying for low-value care. Another example of this is when physicians talk about reimbursement. Do we talk about reimbursement when we talk about any other producers in our economy? No, we talk about prices and we talk about payments. Reimbursement makes it sound like physicians are doing us a favor in ways that other producers aren't, by going out of their way to provide, to go to medical school and to provide these services. Stop talking about Medicare creating barriers to physicians practicing medicine the way they want. Stop talking about Medicare reimbursing them. Medicare is just not subsidizing them the way they want on one hand, and talk about prices and payments instead of reimbursements, as if the Medicare program has a duty to provide physicians the payments they want for what they want to do.
Right. Thanks, Michael. I think we get the perspective. I'd like to hear.
Yeah, I'd like to qualify. So the reason I brought up
on a panel with 3 doctors, by the way.
The reason I brought up that act is not because I support the Medicare Act.
Right.
My point is that it's impossible to do that. Okay, and what would be interesting? I mean, the AMA. People listening should look up. Dr. Ed Annis in 1962 spoke against the Medicare Act very eloquently in Madison Square Garden, and in that speech he kind of predicted exactly what Medicare would turn into. And so, I mean, I agree with the first panel discussing how the AMA is also a very rent-seeking type organization. However, at that time the president knew enough of what would happen, by socializing essentially that part of medicine. As far as Medicare and restrictions and impositions on physicians, I've been able to practice without having the reimbursements, without focusing on the reimbursements of the insurance companies have done because of the specialty I'm in. I just decided that was not going to influence my doctor-patient relationship and what I choose to do for them. Some of the reasons why in ophthalmology we can do that is we have a lot of specialized equipment and staff that can collect a lot of the data I need to make my decisions ahead of time, such that it can make my time much more efficient when I'm with the patient to really just address their issue. And in our surgeries, although they've cut what they reimburse for cataract surgery to a tremendous level, fortunately we were able to get excellent lenses and other procedures through that Medicare doesn't cover. So what you want to do in a specialty is find things that Medicare doesn't cover, because then you can let market forces work. And just like he found in the, Medicare's not covering his services. So there's certain services I can provide that they don't cover. And essentially they subsidize them the rest of my practice. And I can set the fee at what's reasonable for me and my patients. But as far as restrictions, they varied throughout the time. There were periods where if a Medicare patient wanted cataract surgery on their insurance, they still had to submit their visions and a whole bunch of other things to Medicare for an approval board before they could get cataract surgery. There are other periods of time in Medicare where even if you elected not to be on Medicare, they said you still can't charge a patient over 65 a certain amount of money, even privately. So they do affect a lot of things. But and as far as medical decisions, like I said, for me in my specialty, the only time it influenced me the most was when every single patient that had cataract surgery, we had to submit it to an agency and send everything in and get it approved. There was a period of 3 to 5 years or something where that was happening. But I know that it happens a lot more in other specialties. Did you accept Medicare at any point?
I mean, when I worked in emergency medicine, the billing companies had to bill Medicare. So yeah, but now, I've been opted out of Medicare for years. But I think, and I'm no expert on that. There are, I think, tens of thousands of pages of regulations for Medicare. I've been distanced from it for a long time. But I think you have to opt out for what Michael said to be true. If you're a physician that accepts Medicare, there are all kinds of regulations and restrictions that are placed on you. You can't charge a patient anything separate from what Medicare, allows for any given service. You can't negotiate privately with a patient. If you accept Medicare, you're forbidden. Am I wrong about that? You're forbidden from independently contracting with a patient who has Medicare for any service that they cover.
For a Medicare covered service.
Correct.
Which is a restriction on Medicare subsidies. Okay, if Medicare allowed you to do that, that would make the Medicare program more attractive. And could increase Medicare spending. And there are lots of examples of this, like physicians complain about the ban on physician-owned hospitals. There's no ban on physician-owned hospitals. Physicians can start their own hospitals, so you just can't get Medicare subsidies for it. And if we're talking about, and we have to be really careful about this when we're talking about the amount of coercion in healthcare, because physicians make it sound like, oh, Medicare's coercing us by not letting us open a hospital. But if you gave the physicians what they wanted in this case, that would mean that physician-owned hospitals could bill Medicare, they could get Medicare subsidies, and that would lead to more coercion because those numbers would get bigger, not smaller. Those numbers would get bigger. More of U.S. GDP would go toward compulsory health spending, and that means there would be more coercion involved in healthcare, not less. So this is, if we want to be advocates of individual choice and freedom in healthcare, we have to be very careful about this question of is Medicare, when and where is Medicare coercing people? I submit the only time Medicare coerces anyone is when the IRS collects taxes to fund the Medicare program and nowhere else. Everywhere else, we should want more restrictions so that the amount of money that Medicare spends goes down, the amount of tax revenue they have to collect for it goes down, because that is what reduces the amount of coercion that the Medicare program engenders.
So one of the ways to reduce coercion and achieve that without getting rid of Medicare also is let Medicare set whatever fee it wants and then allow physicians to just balance bill. That's something that AAPS, another physician organization, has been promoting, which, it's not what we produced, which was very similar to what he's talking about in 1990, whatever, too, about transitioning Medicare into a voucher. If an HMO can get their money every month, why can't they get it every month, and turn into whatever insurance they want, which is very consistent with what we produced. So, so there's that. But I think that if you balance bill, it allows physicians to want to provide better quality, buy more expensive equipment, or whatever they need to do. At least it lets Medicare patients see those patients. They're not restricted from that quality. Right now, the only way to get that quality is if Medicare does not allow the service. Like, they don't allow special implants, so I'm able to charge for those. But if I want to provide better service or a concierge type service to a Medicare patient, you know, and do a survey, and you know, and let their Medicare pay for it, I can't balance bill the difference. And so by allowing that, it would start to have market forces work, because then patients can shop for all the doctors that don't want to bill any different. They'll just accept what Medicare did, and prices won't keep going up. But patients that want to choose a different kind of service can. So that's a very simple thing, but we've had a hard time getting that through, because I think basically Medicare still wants to control all the doctors and the prices.
So, I mean, one way to think about what we're talking about is, one approach is to try to reform things from the inside. Another is to try to create pathways for practice on the outside. And last night during dinner, we had interesting conversations about different potential pathways of how we could, let's say, Uber medicine by creating something that is so valuable, such that people really demand it. And there were two potential mechanisms for that. One of them was the health sharing ministries that you brought up, Mike, so I'd like to hear about that. And you, Michael, you talked about using U.S. territories as a basis to potentially sell healthcare that's more consumer friendly.
Yeah, so I have some experience with health sharing plans or health sharing ministries, as you know, it's a natural fit with private pay practices like direct primary cares. At one point, I think 15 to 20% of the patients in my membership-based practice were on a sharing plan. I don't know what it is most recently, but basically these are things that were carved out in the ACA. They've been around since at least the 1990s. Started in the Christian community, and basically they're like a mutual aid society like we had before we had insurances. These are, you know, communities that basically agree to share in their medical expenses. It's not insurance, but it's got an ACA sort of exemption, which I think gets these people out of the tax penalty, although I think the tax penalty was rescinded anyway. But at any rate, it's basically a more affordable way for these people to mitigate the expense or the risk of catastrophic care, like what insurance should do and would do in more of a free market setting, at a much more affordable rate, at, you know, typically I think around 1/3 or so the cost of what now is an insurance plan.
So Obamacare has caused premiums for people in the individual market to leap by 100%, 200% in many cases. We know that this is the case because in the so-called short-term market for health insurance, type of health plan that's exempt from Obamacare, you can get insurance. Some people, many people, could get insurance that at premiums that are 60% less than the lowest cost Obamacare plans. The limits on the short-term market, they can only last for so long, and the Biden administration is trying to cripple them. But there are other Obamacare-exempt alternatives, alternative sources of health insurance. In 2014, the Obama administration exempted all health insurance plans in U.S. territories from Obamacare's costliest regulations. So you've got another market there that, like the short-term plans market, is exempt from those regulations and could provide coverage that is not just short-term, but long-term coverage, again, at premiums that are 50%, 60% less than the lowest cost Obamacare plans. And all you have to do, all that a state, and you don't need an act of Congress to give people in the continental, the 50 states, access to these plans. Each state could pass a law saying, we recognize as being in compliance with our health insurance regulations any plan that any U.S. territory licenses. You do that, and residents of Texas, individual consumers, employers could purchase plans from well-known insurers that already operate in the territories like United Healthcare, Humana, Aetna, the Blues, and at premiums that are far lower than Obamacare premiums, without any sort of direct assault on either Obamacare's regulations or the regulations that are in place here in Texas. And once you do that, you could maybe create constituencies that would then preserve that freedom to purchase health insurance across state and territorial lines, and expand that freedom and make those reforms durable.
Michael, can I ask a question? So would that, to make that happen, would it have to be something that the Texas legislature would have to do? This is not a national issue. In the example that you gave with it being Texas, the Texas legislature would have to pass something to make that a viable market for Texas consumers?
Yeah, it would have to be an act of the legislature, unless for some weird reason Texas law gives the insurance commissioner the ability to authorize those sorts of plans, which I think would be great if there were such a weird feature of Texas law. I'm not aware of one.
Yeah.
Thanks, Mike. With that, I would like to open it up to the floor for questions. Please just use your voice. The panelists will, or I will, try to repeat your question for the people that are online. And if you could direct it to a particular panelist or the panel as a whole, please do so. Okay, thank you at the very back first.
Okay, so this is a question for Dr. Garrett. You mentioned that the direct primary care model is like the area of relative freedom, but you said that there are a lot of ways that regulation limits you to practice what you want to. And for instance, Amish said that, I believe he said that doctors who operate in the direct care model are not able to charge for services more than doctors who operate under the Medicare model. So does that restrict, are there services that you wish you could provide that you can't because they're not being restricted?
So I'm supposed to repeat the question, but I didn't get the gist, like the essential part of the question was.
You said that there are ways that regulations do restrict you in practice, concierge practice. You give some more specifics to what those are.
Yeah, so they're not so much from the standpoint of pricing or regulations related to Medicare, since I'm opted out of the Medicare system and completely independent of that. I'm just talking about all the things that both Greg and Amish referred to earlier, which is, there are things I can give you concrete examples of patients that I've had that a woman that I had was a very dearly beloved patient of mine who had idiopathic pulmonary fibrosis. She was progressively losing the ability to get enough oxygen. There was a medication she was taking orally that's available here in the United States, and it was available in some other countries as a nebulized form, which was showing great promise and may have extended her life. And we had I knew about it. I could kind of think about it, but I couldn't get it for her. I couldn't prescribe it for her. There are countless examples like that where the regulations, even in the sort of pocket of freedom that we have, are preventing me, and the FDA is the source of a lot of those, where availability of treatments or medical devices that are widely available in Canada or other European countries, other nations, are not available here. And this is something that when we were talking about this, I think Michael mentioned that, like, if we're talking about trying to find steps towards little positive steps or baby steps, that would be an easy regulatory thing to say, rather than giving the FDA this exclusive ability, this life or death power over United States patients and physicians, to say if a drug or device has been approved in one of these other locations, another major country in Europe or Canada or something, that you can't prohibit a United States patient or doctor from using or considering that therapy. I mean, that seems like an easy step in the right direction to me. So that's an example, and there are many more, but the FDA drives a lot of those.
Sorry, I'm not keeping track of hands.
Okay, I think this question is for Dr. Garrett, but for anyone, I don't know if you've read Peter Attila's book Outlook, which is a bestseller this year. It seems to me that his thesis is that preventative medicine would actually make a big dent in what we're spending up here if we have that mindset. And I'm wondering if you guys see a connection between further government freedom in medicine, letting people see how much they're spending when they get sick, and maybe sort of changing the approach to medicine to get a little bit more health-oriented, preventative, or if that would still be it, or if we would still have kind of what we have today, which is people go to the hospital when they get sick.
Yeah, so I'll repeat that question and take it, and then if anybody else wants to comment. I'm working my way through his book. I'm about a third of the way through it maybe right now. But the question is about Peter Attia's book, Outlive, and him talking about sort of health optimization and lifestyle strategies and trying to improve our both health span and lifespan and focusing more on that rather than treating diseases, which seems to be our model, and whether if more people embrace that, is that the question? Like if more people embrace that, whether we would have less spending or better health outcomes?
Yeah, I think maybe the more you're aware of how expensive poor health is, the more you might take control of it. Individually, these kinds of things might be synergistic.
Yeah, I certainly think that's the case, and yes, a lot of I definitely see that, and that's one of the things that's driven me over the last 10 years in direct primary care and concierge medicine is recognizing, you know, some of the flaws in our current medical model. One of which is that it's a very based on diagnosing and treating diseases and then considering them chronic conditions. And the mindset when I was in training 25 years ago was just these things are just out there. We just accept that. Now you have type 2 diabetes, and that's just how it is for the rest of your life with no consideration. But what I realized is it's definitely the case that you can often reverse these things and put them in remission and get people off of medications through things like lifestyle. And, you know, I think some of these private models allow for that more. I mean, you're not going to have time with a 12-minute doctor's visit in a traditional, you know, third-party payment model to do that. But yeah, I think it's got tremendous value, and yeah, I hope that's helpful.
I think in a free market, absolutely. I mean, that would be obvious, you know. I mean, if I'm healthy, my health care is going to cost less. I mean, and preventive measures, exercise, diet, et cetera, definitely.
If what you care about is preventive care, then you definitely want a free market in healthcare, and you want to eliminate the ways the government has intervened in healthcare. Because, let me give you two examples. I've mentioned a number of times the tax exclusion for employer-sponsored insurance, which effectively penalizes people unless they enroll in an employer-sponsored plan. If what you want to do is encourage preventive care, you want people to have a lifelong relationship with their insurance company, so that the insurance company will have an incentive to invest in preventive care now to avoid expensive episodes of care down the road. But if your relationship with your insurance company lasts as long as your employment with your employer, and the average worker, I think, he switches jobs about a dozen times by their mid-50s, when you penalize people unless they enroll in employer-sponsored insurance, you're penalizing preventive care. Also, both the tax exclusion for employer-sponsored insurance and the Medicare program have encouraged a way of paying providers that discourages preventive care, and effectively one of them subsidizes the competition, the other one penalizes a way of paying health plans and paying providers that encourages preventive care. And again, I'm talking about the Kaiser model. The Kaiser Permanente, more than other, and I'm not a shill for Kaiser. I wish there were more examples out there that I could point to, but government regulation has killed all but one of them. That model encourages the plan and the providers to invest in preventive care, cost-effective preventive care, because they really internalize the savings from keeping you out of the hospital. And yet, both the exclusion penalizes that form of health insurance, and the Medicare program has subsidized the competition for 50-some years now.
All right, questions? Whoever was first.
This is a very entrenched business. It's like no other business, the healthcare industry. I've heard a lot of different things. People like my parents have been on Medicare for quite a bit of time right now, so you don't think that's going to change. You have high constituency. They're not going to vote a certain way. You four up there on the panel, what's 2 or 3 things that can happen in the short term, long term that'll have the most impact? Maybe start with the younger generation, or with the states divided. I mean, we're not going to have like a day and night off and on switch right now. I mean, what is like the biggest legislation policy that changed in the next couple of years that can make a big impact?
Right. So just to repeat the question for people online, he's asking what's the most concrete steps that we could take towards was it reforming Medicare?
Well,
Or
everything, healthcare industry in general,
everything.
the biggest impacts.
Yeah, the biggest impact policy proposal.
Well, I think the two things are clearly the tax equity for individuals so they can start in the market, and then allowing Medicare recipients to have a voucher, not making them have a voucher, continue the exact same system it is, but let them take the dollars that they would normally give an HMO and give it to the patient, and free up the insurance industry to create products for that market. But you're right, you'd never turn the switch over. The plan that we put in our health plan was over 30 years. People that were 30 and under, they never had to, anything they paid into Medicare was given back to them at a certain time. And then we phased it out and extended the ages and so forth, but allowed everybody to have medical savings accounts to be able to cover for that. And we showed actuarially why and how that would work over a 30-year period. But that, yeah, you can't possibly do it immediately, and it would be unfair. You know, even though the whole system's not really fair, but we're paying for it for we're paying for my health care from my kids and my grandkids. So,
Any quick responses?
Let workers control the $1.3 trillion of their earnings that their employers control and use to choose their health plans. Let the workers control that. Again, about $24,000 per worker with family coverage in an account that's just like the health savings accounts, but keeps the best parts and gets rid of the worst parts. You acclimate, that'll cause prices to plummet. That I think it is politically achievable. There's stuff in that idea for both Republicans and Democrats. And over time, it will acclimate people to, accustom people to making their own health decisions so that when they get to Medicare, they really won't want Medicare anymore and they'll demand reform there. You could get a demographic wave of Medicare reform voters that would, you're not going to get right now with a cohort of Medicare enrollees who don't know anything else, don't know anything better.
Yeah.
Couple of quick points. First,
I'm not sure we can repeat the points depending on how long they are.
no, they'll be very brief.
Okay.
First, I want to reemphasize Michael's point that the word reimbursement should be banished from all discussions of policy. Doctors are paid. Reimbursement is a euphemism. We shouldn't be talking in terms of euphemism. Secondly, I want to make the point for the question here that many forms of preventive care are wildly overhyped. Take colonoscopies, according to Vinay Prasad, who I think is the leading commentator on the science side. The only examination of that type that has any robust evidence of its tendency to reduce all-cause mortality is the sigmoidoscopy. There's no such evidence for colonoscopies, yet we spend close to $50 billion a year on screening colonoscopies. That's, you know, an example of low-value care. The question about the whole group, though, was a complete shift, and I apologize for this because it may be unfair. We seem to have multiple crises that are impending at the same time. One is, you know, Medicare is just chronically insolvent. The other is that the baby boom generation is aging out, so we're going to have massive increases in spending, and at the same time, we're also going to have a nursing home shortage. What are we going to do about that combination of things, right? I think we do have a problem that's staring us in the face. So, if I get your thoughts on
Right. So to summarize your points, a lot of preventative care is low quality, and you are advising against using the term reimbursement because you regard it as a euphemism, right? And then your question, right? And then your question was basically, we have all these fires putting out. How? Right. There's so many fires. Like, how do we put them all out? Like in a coordinated effort. Is that correct? Yeah. Okay.
You can't put them all out. There's no nirvana. There's some people are not going to get some stuff, and the problem you're describing is that Congress has promised so much, and the cost of those promises is so exorbitant that either some people are not going to get what Congress has promised, or Congress is going to have to take even more money from people in order to keep all those promises, and then they're going to have to give up stuff like housing or education or that sort of thing. So I don't know what the best answer is in terms of how we should allocate those resources, I think the most important thing we can do to make the coming adjustments or the how often we have to say no to people as painless as seldom and as painless as possible is we have to focus on getting healthcare prices down. We have to make it so that everybody's healthcare dollar goes farther so people can get more of the healthcare that they want. And the best way that I think anyone knows for getting those prices down, which should be job one, and if you care about universal healthcare, is you need to change who controls the money. So the things that I've already discussed, letting workers control that $1.3 trillion, letting Medicare enrollees control the $1 trillion that Medicare spends on their behalf, turn it into an adjunct to the Social Security program. When you give consumers control of that money and make them price conscious in a way that they're just not right now, prices are going to plummet for all sorts of medical services, and we could do a similar thing with Medicaid that could have a similar effect on long-term care, so that more people can access these resources because the prices are so much lower. Mm-hmm. Now, you'll notice I kind of made it sound like we wouldn't be saying no to somebody under that scenario, or we'd be saying no less. We would be saying no to someone. Falling prices are the market's way of saying no to someone. They're the market's way of saying no to high price and in many cases low quality providers who should be making less money. It doesn't bother me saying no to them because they are wasting societal resources that could be providing more value and making people happier in other uses. Falling prices represent the market saying no to those inefficient providers, and I think I think it's imperative that we do that so that we can give consumers more of the things that they want, and that doesn't mean that rationing is still going to exist, mm-hmm. Even though prices are lower, but falling prices mean that rationing has to happen less often.
Art, I'd like to give you the last word, and after that we're going to go on to our next panel.
Okay, yeah, I wanted to thank you for bringing up, I think Peter Chia's book is excellent. I think it has some very good concepts for medicine, his concept of medicine 2.0, which is where we're at, and developing what he calls 3.0, which is really, even in medical school, we really did just learn, okay, someone gets diabetes, you treat it, right, as opposed to actually preventing it, but all those have to do with what Greg talked about earlier, which is individual life choices. I mean, we all value things differently. Some people value their alcohol, but every sip you take kills brain cells. but you're choosing that because you like it, right? And the same thing with diet and eating and how much time you spend exercising. So all that comes into it, but because many people don't spend their own healthcare dollars, they may not even think of the consequences of those activities. They might think about it more. And so I think clearly the things we mentioned, getting the dollars in the hands of individuals to make decisions is clearly the way to start. And the thing you commented on, like colonoscopies, I don't necessarily agree. I mean, Peter Attia in his book doesn't agree either, because he thinks if you got a colonoscopy every day, we'd eliminate colon cancer. But needless to say, the point is that in a market, people would be free to choose their preventive care, right? It wouldn't be the HMO or Kaiser or anyone telling you what you have to do for your preventive care. You would see the people you want to believe and help you. So clearly the markets are the answer. I think preventive care and this 3.0 medicine is going to help reduce costs, but nothing like having the dollars in individuals' hands to make choices.
Thanks, Aaron, and I would like to thank all the panelists.